So good afternoon and welcome to this public meeting of the Physician-Focused Payment Model Technical Advisory Committee known as PTAC. Welcome to the members of the public who are able to attend in person, and also welcome to those on the phone or over the live stream. Again, thank you all for your interest in this meeting. This is PTAC's sixth public meeting that includes deliberations and voting on proposed Medicare physician-focused payment models submitted by members of the public. This meeting also marks 2 years of the PTAC being open for business and available to receive models from the public. Over the last 2 years, including the proposal we will deliberate on today, we have received 28 full proposals. We thank the community of stakeholders who have put in the time and energy to submit these proposals. Your hard work and dedication to improving our healthcare system is greatly appreciated. I have some updates I would like to share with you before our deliberations get underway. First, you may notice some new faces around the table. Well, we have one new face, that's Dr. Jennifer Weiler, who comes from the University of Colorado School of Medicine. She's an emergency medicine physician, so welcome, Jennifer. We also have on the phone our second new member of the PTAC committee, and that is Angelo Sinopoli, who's an internist by training and comes to us from Prisma Health and the Care Coordination Institute in South Carolina. He unfortunately, his flight was snowed in, but he is active and fully engaged in participating in today's meeting. These folks have already hit the ground running. Both are already active on preliminary review teams looking at new models that we recently had submitted to the committee. In addition, I'd like to acknowledge Dr. Grace Terrell, who has recently agreed to serve as the PTAC Vice Chair. Having worked with Grace on the committee for the past 3 years, I know the committee will greatly benefit from her leadership, her expertise, and also her creativity in her new role. Emphasize creativity. So, the members of PTAC have been hard at work since our last public meeting in September. In addition to the proposals we'll be reviewing today, our preliminary review teams are actively reviewing 4 proposals. You also may remember that earlier this year we issued a request for public comments on our processes and requirements. A summary of the public comments and actions the committee is asking to take as a result can be found on the ASPE PTAC website. Today we will also be debuting new voting categories for our overall recommendations to the Secretary. We believe that these voting categories, which are more descriptive, will be able to better reflect our deliberations and recommendations to the Secretary. After we vote on whether the proposal meets each criterion, we will proceed to vote on our overall recommendation to the Secretary. First, we will vote using the following 3 categories: not recommended for implementation as a physician-focused payment model. The second category is recommend, and the third is referred for other attention by HHS. We need to achieve a 2/3 majority of votes for one of these 3 categories. If a 2/3 majority votes to recommend the proposal, we then vote on a subset of categories to determine the final overall recommendation to the Secretary. The second vote uses the following 4 subcategories. First, the proposal substantially meets the Secretary's criteria for PFPMs. PTAC recommends implementing the proposal as a payment model. Second, PTAC recommends further developing and implementing the proposal as a payment model as specified by the PTAC comments. Third, PTAC recommends testing the proposal as specified in PTAC comments to inform payment model development. And fourth, PTAC recommends implementing the proposal as part of an existing or planned CMMI model. We need a 2/3 majority for one of these 4 categories. Today, we will deliberate on one proposal before we host a general public comment period. To remind the audience, the order of activities for the proposal is as follows. First, PTAC members will make disclosures of potential conflicts of interest and announce whether they will not deliberate and vote on the proposal. Second, discussion of the proposal will begin with a presentation by the preliminary review team. Following the PRT's presentation and some initial questions from PTAC members, the committee looks forward to hearing comments from the proposal submitter and the public. The committee will then deliberate on the proposal. As the deliberation concludes, I'll ask the committee whether they are ready to vote on the proposal. If the committee is ready, each committee member will vote electronically on whether the proposal meets each of the Secretary's 10 criteria. This voting has not changed from prior public meetings. The last vote will be on an overall recommendation to the Secretary of Health and Human Services using the new two-part voting system I just described. And finally, I will ask each PTAC member to provide any specific guidance as ASPE staff, or to ASPE staff, on key comments they would like to include in the report to the Secretary. A few reminders as we begin discussions today. One, PRT reports are reports from 3 PTAC members to the full PTAC and do not represent a consensus or position of the PTAC. These PRT reports are not binding. The full PTAC may reach a different conclusion from those contained in the PRT report. And finally, the PRT report is not a final report to the Secretary of Health and Human Services. After this meeting, PTAC will write a new report that reflects the deliberations and decisions of the full PTAC, which will then be sent to the Secretary. Our job is to provide the best possible recommendations to the Secretary, and I expect that our discussions this afternoon will accomplish this goal. I would like to take this opportunity to thank my PTAC colleagues, all of whom have given countless hours to the careful and expert review of the proposals we receive. Thank you again for your work, and thank you to the public for participating in today's meeting in person via live stream or on the phone. So before we get started, I would like to follow up to a discussion that we had at the last public meeting, which was providing an update on the status of the Secretary's response to our discussion around the models that we've already approved and what activities CMMI has been doing to date. We just concluded an administrative call with the director of CMMI, Adam Bowler, who we have been speaking to between the last meeting and today. There are models in flight that are based on the submissions from the proposers that are going through the approval process now. We're not certain of the exact timing on when these models will actually be announced, but we anticipate that it will be sometime in the first quarter of 2019 of next year. Some of the categories that are under consideration include a primary care model, a kidney care model, an end-of-life model, and there are others under consideration that we'll hear more about, hopefully, by the next meeting. Adam Bowler plans to come and address the public at the next meeting. There are also there's a letter that is under construction that will be released soon that will include guidance on the areas of focus that CMMI is interested in driving forward relative to alternative payment models. And that criteria will include the kinds of models that they are looking for, the kinds of elements that will be in those models that will take particular interest from CMMI. And I also welcome my PTAC colleagues who've been in those discussions with Adam. But we think that this extra guidance will be very helpful as stakeholders figure out who to speak to, whether to come to PTAC, whether to work directly with CMMI. And we think that this letter will include guidance around how to navigate that decision-making based on the proposal elements that are under consideration, which will help the submitters prior to actually creating and going into depth and building a proposal. With this guidance, they'll be able to incorporate some of the anticipated attention that CMMI will be taking futuristically, which will help us as a committee, but also help the stakeholder community sharpen their focus on what models make sense going forward. Before I launch into the review of the model today, do any of my colleagues want to add to my comments summarizing that update? I believe Dr. Sandy Marks from the AMA will be making additional comments, who has been speaking with the stakeholders to get their input as well, the proposers who have been working with CMMI. I think we'll hear more about that, but did I miss anything relative to the update we wanted to provide as a committee today? All right, hearing none, then let's go ahead and get started. The proposal we will discuss today is called Making Accountable Care Sustainable Oncology Networks, or MASON. It was submitted by the Innovative Oncology Business Solutions Incorporated, and we're going to go ahead and hear from the PRT. Before we do that, we have to have our disclosures, our conflict of interest disclosures, and I'll start with myself, and we'll introduce each other as well. So Jeff Bailett. Dr. Bailett, I am the Executive Vice President for Healthcare Quality and Affordability with Blue Shield of California. On this particular proposal, I have one disclosure to share. I served on the American Medical Association Large Group Advisory Board, advising the AMA Board of Directors for 4 years, ending in 2012. Dr. McEnany was on the AMA Board of Directors at the time, so she attended our quarterly meetings for the last year or so. I also testified before Congress as one of 4 physicians, including Barbara, in April of 2016. I've indicated these items on the form, but I don't feel that they represent a significant conflict, but wanted the committee and the folks at ASPE to be aware of that.
I'm Bruce Steinwald. I'm a health economist here in Washington, D.C., and I have nothing to disclose.
Paul Casal, cardiologist, executive director of New York Quality Care, the ACO for New York Presbyterian, Columbia, and Weill Cornell. I have no disclosures.
Hello, everybody. I'm Harold Miller. I'm the president and CEO of the Center for Healthcare Quality and Payment Reform. I was not involved in this proposal, and it would not have any effect on me, but I have worked with Dr. McEnany over several years on oncology payment issues, and I realized when I read through the proposal that part of the model is based on the patient-centered oncology payment model that I worked with the American Society of Clinical Oncology on several years ago. I've also visited Dr. McEnany's practice in New Mexico, the Albuquerque version, not the Gallup version of the practice, and have provided information to her and to Laura Stevens, who's the COO of IOBS, on several occasions. I also do consulting work for the American Medical Association, and Dr. McEnany is the current president of the AMA. So while I don't have any financial conflicts, just to avoid any appearance of bias or favoritism, I'm going to recuse myself from voting and from participating in the deliberation on the proposal. I do know a lot about oncology payment in general, and if there are factual questions about the current payment system, I'd be happy to answer them for my colleagues if that would be helpful, but I'm not going to engage in any deliberation on the proposal itself.
I'm Jennifer Weiler, Professor of Emergency Medicine at the University of Colorado. I'm also Executive Medical Director of UC Health's Care Innovation Center, and I have nothing to disclose.
I'm Lynn Nichols. I run the Center for Health Policy Research and Ethics at George Mason University, and I'm a health economist. I don't have anything that rises to the level of a real conflict, but since we're being so phenomenally open and honest, I'll just say I once had a drink with Barbara in a bar. It was with Ian Ian Morrison from Canada, and he paid for the drink because he makes more money than we do. So anyway.
I'm Grace Terrell. I'm the CEO of Envision Genomics, a practicing general internist at Wake Forest Baptist Health System, and on the board of CHESS, which is a population health management company, and I have no conflicts to disclose.
Dr. Sinopoli.
Yes, this is Dr. Sinopoli. I am a pulmonary critical care physician and the Chief Clinical Officer for Prisma Health in South Carolina, and also CEO of the Care Coordination Institute, which is an enablement services company and I have no conflicts and nothing to disclose.
Thank you. So we're going to turn it over to the proposal review team, and that's led by Dr. Grace Terrell. Grace?
Thank you, Jeff, and thanks, everybody. One of the coolest things I think about PTAC and MACRA legislation, if we take advantage of it, is it's at least the only example I know of where the federal government actually asks the stakeholders who actually practice medicine and run medical businesses to contribute to the ability to think about healthcare policy in ways that can make a difference for all of us. And so within that context, I very much and my colleagues appreciate the Mason proposal. It comes from the context of an organization that has participated in the oncology care model that's now one of the standard models that's been one of, through Come Home, one of the Hickey Awards that looked at how to think about models of care that would make a difference with respect to resources and how they might be better used to provide care for patients who have cancer. And who, from that experience, had the ability, as well as running a private business in a non-hospital based oncology practice, understanding what some of the limitations were, as well as learnings from the types of things that they thought might make it better. And so out of that comes the Mason proposal. And within that context, I think the proposals of it, and am just grateful that we have the opportunity to be thinking about things from the field that stakeholders are bringing. This is a perfect example of one that comes from that context. The PRT review committee consisted of myself as lead, Bruce Steinwald, as well as Bob Berenson. Bob Berenson, I don't know, unless he's on the phone listening, is not with us today because he's rotated off the committee, but certainly has been very much involved in the analysis, and actually all the work with respect to this was done prior to his rotation off. I think maybe the hour before or something like that. We were still working on it, but got it done. So making accountable sustainable oncology networks is the name of the proposal. We've just heard about the team that did it, the PRT, and who we are. The proposal overview is for those of you who are familiar with our process. I won't go through it in great detail because it's become a real standard, but this one was a little bit different because this one, at least from my point of view, was the first I was involved in since the change in legislation that allowed us to give some preliminary feedback. And so in many ways, it may have prolonged the review process, which is why it was not done in September like we originally thought it was, but is here in December, and Bob had actually already rotated off by that point. But on the other hand, we've learned from that process, and I believe that as a result of that, several of the changes that occurred made this, at least from the PRT's perspective, a stronger proposal. So typically what happens is that the PTAC chair, vice chair assigns 2 to 3 PTAC members to review. Then additional information is requested. In this case, we spoke to OAC, we spoke to CMMI in both cases about the oncology care model that was out there, as well as the Come Home award that this same group had been involved with. We asked in written questions of the proposer, got those back, had an interview with them, and then subsequent to that created a sort of early PRT type report that was allowed to be the initial feedback. So the reason I'm going through this in this time is because that's the new component of it. From that, we got more iterations, more interviews, more discussions, more answers, and ultimately some changes from their original proposal. And subsequent to that, we wrote up our recommendations which you all have all now seen and which I'm going to go over as we go forward with it. But that was the process that we went through. It was quite thorough, and we had a significant amount of information that we evaluated, both from the proposer themselves, written and orally, but also from other sources. So this particular model and proposal is based upon Come Home. So Come Home was part of a CMMI grant that was done from a group of oncologists that were part of a consortium. And with that, they created out of that grant some processes in place for which they were able to show that care coordination and other types of processes that they developed saved substantial money off the awards once they were evaluated. I believe it was something like 6.3%. Overall, some of that was reduction in high-cost services like emergency departments. And based upon that, which was not sustainable since it was part of just the grant and the award, they did a lot of substantial thinking, also by participating in the oncology care model, on a payment model that might occur that could improve on that work, as well as create the opportunity for something that could be sustainable as part of a PTAC proposal that went to CMMI. So that's what this is. The core elements are that it starts with the first consultation with an oncologist. It's based on the relevant clinical factors that and the patient preferences. Many of this is work that was done related to thinking about the Come Home care model. They are assigned to a treatment plan at that point that has a target price that is essentially reflects all cancer care related expenses, but excludes drugs from the overall OPC, which is a target amount that is established based upon practice pathways, as well as some artificial intelligence related ways of thinking through in great detail the pricing that might be appropriate for that level of care. The OPC assignment prompts the creation of a virtual account. The usual types of fees are charged in the usual types of way, whether it's a DRG or whether it's fee-for-service physician payments. And all that is kept in a virtual account, and then retrospectively, based upon what the expected cost would be, there's a true-up at the end. If the patients are managed in a way that reduces their expenditures below the target amount, then the practice is sharing those savings, provided that the quality benchmarks are sufficiently met. And the quality is measured via pathway compliance, patient and family surveys. These pathways are established and developed by this national consortium based on evidence-based guidelines that is also with contribution from the academic centers as it relates to these guidelines. Because of the nature of oncology practice, which is changing faster than everything else, not only as it relates to drugs, but as well as genomics, in many of the other aspects of care that's changing in real time, the OPCs are a work that changes over time, and that's one of the real issues in this model that we need to think about, because it's something that has to basically set established pricing, but at the same time has to go for best evidence in real time in something that's changing very, very rapidly. And so those are the issues that this model tried to resolve and solve and come up with a solution with in one of the most complex areas there is in healthcare today. So to basically think about this, there is a target price which is called an OPC, and these are basically established based on disease state, comorbidities, treatment plan. That's the expected cost of care for patients in a given OPC. It's really important when you see the PRT's evaluations to understand that these have not been developed yet. And that's really one of the keys to some of the analysis that we had. I don't necessarily personally think that that means that that it's a negative or adverse recommendation that we give. It just means they're not developed yet. And this is an ongoing field, and a lot has to be thought through with respect how you get from point A to point B in a system that's evolving in real time. So there is a one-time $750 payment for new patient consultation. The E&M visits are also part of that. Infusion center facility fees are part of that, as well as the variable radiation and infusion inputs, hospital charges and facility fees, and any other patient care charges, physician care that's related to cancer treatment, imaging and laboratory services, but it excludes non-oncology services. So part of the real aspect of this model is that it's related to cancer care and those things that the oncologist can control. Quality is based upon a 4% withhold from all E&M payments that's used to form a quality pool. The quality is measured by a technical quality in terms of looking at its variation from the treatment pathways that have been established, and customer service quality in terms of patient and family surveys. And for both criteria, there is an 80% threshold established as defining satisfactory performance. So to summarize the PRT review, we felt that the scope, which is one of our high priority designations, that this absolutely meets criteria and deserves priority consideration. Cancer care is highly complex. The entire business is changing. This particular model is based on some very deep thinking from people in the field running a business, trying to understand how it might best be modeled in ways from a payment and delivery standpoint that could be sustainable given the changes that are going on. From a quality and cost perspective, it was unanimous that it did not meet. Again, this was mostly related to the fact that these OPCs have not been fully developed and established and operational yet. Likewise, for the payment methodology, our does not meet is based upon the same etiology of rationale and reasoning on our part. From a value over volume, we felt it meets. Flexibility, clearly this is flexible relative to some of the other options that are out there. Ability to be evaluated, we believe it meets. The integration and care coordination, we believe it meets, particularly as it relates to the come home things that have already been developed and established. Patient choice, patient safety, and health information technology, we all believe it meets. So we identified some key issues. The first one I've already mentioned, which is the OPCs are not currently operational. And developing them is going to be a time-intense process that will require frequent and similarly time-intensive updating to reflect the ever-evolving developments in both pharmacology, therapeutics, and diagnostic testing, actually, too, with respect to genetics. That's the ongoing reality of the current situation in oncology. There is a granularity of care that the OPCs are evaluating that is much more granular than what we currently see in the oncology care model that's one of the CMMI models or other things that are out there right now. But they are based on utilization patterns that would be from a select group of practices that make up this consortium. And so one of the issues out there was, can this be generalized for the entire population that does oncology in the U.S. or not? So this isn't anything that we necessarily think can't or won't be done, but it has to be evaluated further since this is just a small group of oncologists, and there are a group of oncologists that are already pretty evolved, if you will, with respect to looking at alternative payment models and working with some of the changes that are going on out there. We were also concerned about compliance within the pathways and how they were assigned, and whether the deviations that are voluntary can be distinguished from unexpected events that trigger clinically necessary protocol changes. So this, again, is a part of the issue of if you don't have this thing entirely baked yet, because you have to bake it, we just don't know that we've got that level of detail or fixed yet. And then we had some operational concerns about the adjudication of claims and services based upon some of the description of it in the report, in the proposal that we got. When we went back and asked in more detail about there was some more information that was provided to us about looking at cluster codes to help us make those determinations. Again, the issue was that, as opposed to an appeals process, but the issue was this is new machine learning types of approaches, and it has not, as of yet, it's been untested. We believe that the clinicians have the opportunity to go and justify being off pathway, but we don't know how that they will be really factored into the quality scoring. So you get the sense from what I'm telling you that what we really found as concerns are the details in many respects that have not yet been developed. The model's effort to delineate cancer and non-cancer care may disincentivize care coordination between core team members of cancer care providers. This is just something that needs to be thought through. The PRT would like to see a more robust and detailed plan for shared decision-making. A lot of this starts at the treatment plan. That's when the payment starts for the initial consultation. That we believe all the way through more development of language around shared decision-making could make this a stronger process. And the process for and implications of patients exiting the model probably need to be more fully described and understood. So I am going to go quickly through the criterion so that we can have adequate time to go in greater detail with the proposers themselves, and so the committee members can ask more detailed questions. So again, we thought that it met the scope. We think it's really important for there to be alternative payment models in oncology that are above and beyond what's currently out there with the current model. This proposal acknowledges the granularity, and it is not based on predefined time frame, which we like, as opposed to the current model out there, which starts specifically with the initiation of chemo and only goes for 6 months. And as the proposals made perfectly clear to us, that's not necessarily the way that cancer works for a patient in the real world. And the type of thoughtfulness they put into alternative payment models around there that's really looking at the time of treatment is not time-based, we felt was a real positive. There is a direct incentivization for the care to provide care coordination, which we thought was a real positive. And the payment model attempts to hold oncologists accountable for cancer-related expenditures, which are the things that they have control over, as opposed to the total cost of care, which they assert that they do not. With respect to criteria 2, the quality and the cost, as I mentioned before, a lot of this has not been completely baked or developed yet. Nonetheless, using evidence-based treatment pathways and measuring and rewarding based on clinical quality is a clear strength of the proposal conceptually, and one that we believe, if it goes forward, ought to be developed and developed in great detail. We were concerned about how these things that would be done, how these target prices would be established, since it's not currently operational. They provided us some detail with respect to that, but the biggest hang-up we had is it just wasn't operational yet. So it was, a lot of it was them thinking through a process they would like to put in place. There was also concerns about the generalizability of this based, again, on the patterns of recurrent group. And then the compliance with the pathways. Maybe you shouldn't be compliant. This is, in anything that you measure, there's always the potential that measurement can lead to adverse outcomes as people's behavior is changed by that. This will be true in anything that is established, so the real issue is not that this means it shouldn't be done, but it needs to be acknowledged and managed. From the payment methodology, again, the clear strength of the proposal is just an attention to care coordination based upon the come-home work that was done that had cost of care and high quality associated with it from the previous work at CMMI, and the fact that it was based on cancer care rather than the total cost of care. We were supportive of the inclusion of administrative fees related to drug purchasing and administration. Obviously, there's been some stuff that's come out from CMS since this proposal came on that may make that less of a factor. Initially, there was a 2% plus invoice pricing. That was one of the criticisms that, with initial feedback. When they came back with their proposal, this was what was proposed. We like it, but that actually may be moot now given some of the other things that's happening at CMS thinking about the drug pricing. There was thought process on their part that HCC coding could be used to think about predictors of cancer-related expenditures. That did not, but because that has not really been developed or for cancer as a way of determining, although it may identify patients at higher risk for not only cancer-related but non-cancer-related severity index. It's never actually been used in this way, so it's something that would have to be thought about differently. And the process of adjudicating whether it was related to cancer care or not obviously could be the new fight, right? You know, because since it's just going to be for cancer only, then what becomes cancer care related as it relates to expenditure? So these are just things that have to be thought through. With respect to value over volume, the review of the counts and the process of identifying providers delivering low value care as related to pathway is compelling and would likely improve cancer care. The payment model addresses the previous criterion, such as practical issues related to isolating cancer care expenditures. But this also will create some complexity in the model relative to just looking at total cost of care like the current model out there does. And again, how you actually handle those deviations from pathway at the practice level as well as at the federal policy level has to be really thought through to create a situation that's flexible, simple, and not overly complex, which gets us to flexibility. We like the ability of these evidence-based pathways to change in real time, to basically look at the fact that not everything is going to be on a pathway and be able to focus on that. There may be some benefit that could happen from a more nuanced process of accommodating deviations from the quality measurement process in terms of understanding why somebody went off pathway. It's not really clear how this would be put into the current model. We believe this has the ability to be evaluated. The submitter was very articulate with respect to the types of metrics that could be evaluated with respect to quality of care, cost, and patient satisfaction. Again, the as of yet undeveloped nature of the OPCs and any lingering concerns we have is really related to that. And then there's concerns about how we would use the OCM patient cohort as a comparator, because one of the things that was proposed is, well, let's compare this to the ones that are currently in the OCM model, but perhaps that's not the best comparator group. Maybe it needs to be oncology care at large. We think that there is significant integration and care coordination strength with respect to cancer care. We do believe this is more inclusive of independent practice physicians than perhaps the current models that are out there are. We are somewhat concerned about the model's effort to delineate cancer and non-cancer care as it relates to the payments and some of the complexity related to that. Believe that the emphasis on spending and granular detail on spending is going to be a real plus as clinicians are able to see the data, as the public's able to see the data and come up with ways of actually improving on the efforts that they have. But one of the potential concerns is because they'll have the ability to exclude high-cost clinicians, that may not necessarily generate highest quality team or even overall cost savings if sometimes high cost physicians are high cost because the most complex patients go to them. So that just has to be thought through. With respect to patient choice, it's explicitly stated that the patient preferences for providers and hospitals will be solicited and accommodated. There was some other descriptions of other aspects into including applications And there may be, again, some benefit from a more explicit or detailed shared decision-making plan as part of the model. Again, there was some concern about the cumbersome process of switching OPCs as cancer changed or diagnosis or pathways changed, and any type of impact that might have on patients if that occurred. And then the processes for exiting the model were not fully described, but then again, we only give them 20 pages. And we've got plenty of other types of information out there that they were thinking through these things. We think that the evidence-based pathways is clearly a win for patient safety and will likely yield improvements, particularly because it's groups of clinicians working together across the country in consortiums to come up with evidence-based pathways. The data capture will also improve this as learning occurs in real time, and the transparency will as well. Health information technology was all over this proposal, everything from machine learning to looking at clusters as it relates to thinking about deviations from the pathway. So I don't even have to go into 10. It's just sort of a given. We thought that it certainly met all those criteria. That's it. I'm sticking to it. Bruce, do you have anything you want to add?
Just one. You've made it clear that our principal reservations had to do with the development of the OPCs. But I note that in their recent response to the PRT report, they state, and I quote, "The oncology payment categories are not only possible, but have been produced and can be modified in a timely manner to accommodate changes in care." I'm looking forward to hearing more about that when Dr. McEnany and her team approach the table.
Yeah. So I'm hoping that most of the deliberations this day will be questions that are directed at the applicant rather than me or Bruce or the spirited Bob. But if we have any direct questions that you all need us to answer right now, I'll be happy to do so.
Len?
I was just going to move we bring up the presenters because I think you've done a fantastic job. It's all about the OTC, so let's play the game.
All right. Dr. McEnany and team. So just to level set, it'd be great if you could introduce your team, and then we're going to have opening comments from you for 10 minutes and then open it up to exchange between the committee and your team. Thank you, Barbara.
Thank you very much, members of the committee. I'm Barbara McEnany. I'm a practicing oncologist in New Mexico. I am AMA president, and I did have the Come Home Innovation Center grant. I'll have Cameron introduce himself and Terrell as well.
Good morning. My name is Cameron Baumgartner. I am the Chief Technology Officer of a data science and analysis consultancy known as RS21.
Good morning. My name is Terrell Jordan. I'm the President and CEO of Regional Cancer Care Associates out of Hackensack, New Jersey.
Making Accountable Sustainable Oncology Networks, MASON, is the next step in the transformation of oncology services from fee-for-service to an alternative payment model. In November of 2017, CMS requested pilot projects to develop APMs that could be scaled across multiple sites of service. MASON is a pilot using a group of practices willing to open their EMRs to combine with claims data using advanced data science to prove to CMS and to oncologists across the country that we can create an advanced APM for oncology. The transformation began with IOBS's CMMI award, Come Home, which showed that independent practices transformed into oncology medical homes could intervene early in the toxicities of cancer and its treatment and avoid hospitalization. Come Home provided patients with services delivered by their doctor's practice, kept patients healthier and able to spend more time at home, resulting in healthy, very satisfied patients. Come Home also saved a significant amount of money per patient. However, Come Home lacked a payment system to support the patient services that constitute an oncology medical home. The savings, which were considerable, came from the avoidance of hospitalization, but the expenses fell to the practices without the reimbursement process. A team of physicians and health economists for the American Society of Clinical Oncology developed a more accurate payment system to pay the medical home costs, known as the Patient-Centered Oncology Payment System, and is incorporated into Mason with permission from ASCO. CMMI's Oncology Care Model, OCM, implemented the first attempt at a payment system, adding MEOS payments, Medical Extended Oncology Service, and a shared savings model. To become an advanced APM, practices were to take two-sided risk, where their total costs of care were compared to a target price. Only a third of practices have shown savings, and so far no practices have accepted two-sided risk. Mason is a model built on the foundation laid by the OCM to solve the problems encountered by practices. One, the lack of accuracy of the target price. Two, the inability of practices to manage the entire cost of care. Three, the inability of the OCM model to keep up with the rapid technical advances of care, including new drugs. And four, the lack of real-time data that allows practices to make mid-course corrections in care. As shown in slides 3 through 5 in your deck, costs of care vary significantly for factors not put into the OCM model, and the R-squared correlation between the actual cost of care of come-home patients with the oncology care model targets is 0.33. Practices would be irresponsible to accept risk based on these targets because the possible required repayments could exceed the ability of the practice to repay, resulting in practices leaving the model, depleting the infrastructure of cancer care by going out of business, or doubling the amount CMS pays for care by selling to a hospital. We address excess risk by having NCCA, National Cancer Care Alliance practices, jointly purchase a captive insurance product as stop-loss insurance. The practices remain at risk for the quality withhold, the cost of practice transformation, the cost of the reinsurance, and for patients whose cost overrun is small enough to handle without a claim, but are protected from practice-ending risk. The entire cost of care was included in OCM because of the inability of the OCM model to segregate oncology-related costs from other costs of care, and we will demonstrate a methodology that will leave the oncologists at risk for only those costs related to cancer. Mason removes all drug prices from the model and reimburses the oncology practice for the invoice prices of the drugs. This not only removes the major reason that oncology practices were unable to hit the OCM target, but reassures both patients and CMS that drugs are not selected for a better margin or avoided because the new, better biologics would cause the target to be missed. We want a transparent selection of drugs, and we never want to put a physician in the position where doing the right thing for a patient causes an adverse outcome for the practice. It also eliminates the concern of the practice that a patient with a pre-existing condition requiring a biologic agent or with serious expensive comorbidities would adversely impact the financial performance. We never want a system that penalizes doctors for caring for complex patients. Quality of care consists of customer service, delivering the care the patient wants, when and where they want it, and by whom, and technical quality, delivering the treatment plan that optimizes the goals of the patient. The medical home processes have been shown in Come Home to generate excellent customer service, resulting in patient satisfaction scores in the high 90s. Technical quality of care consists of the patient being offered all of the options for care that are appropriate while avoiding inappropriate care. The gold standard for quality is the NCCN guidelines. With the assistance of NCCN, Mason will help transform those guidelines into pathways embedded into the practice EMRs. Electronically proven compliance with the pathways will include failure to deliver appropriate care, as well as the delivery of inappropriate care, and actual causes for deviations can be built into that too, so that the physician is not penalized when a patient, for example, elects to refuse recommended care. For example, if a patient with a rectal cancer is not offered preoperative radiation therapy with chemotherapy or is not referred for resection, the oncologist would be off pathway, unless the patient had refused, and would sacrifice their quality withhold. Similarly, if excess imaging or inappropriate chemotherapy were delivered, the oncologist would be off pathway and the quality withhold would again be returned to CMS. Part of the technical quality of care is the patient safety components of having an infusion facility certified by the ASCO COPI processes that meets regulatory standards, a radiation facility that is ACR accredited, and appropriate accreditation of surgical suites and hospitals. As the drug margin has been used to pay for the infusion fee, we are removing the drug margin. A facility fee will pay for the fixed cost of having the appropriate COPI-certified infusion facility, and the cost should be the same regardless of site of service. The oncology payment category is created via data science techniques. The target OPC amount is visible to the practice and to CMS as a virtual account. Every non-drug claim that is submitted related to cancer care is subtracted from the virtual account, allowing the practices to monitor patients with increased needs or physicians using excess resource use. I'm now going to turn this over to Cameron, who will demonstrate the OPC.
Thank you. We have created a proof of concept to demonstrate the feasibility of quickly creating and updating the Mason OPCs. We have used the clinical and demographic data of 2,500 episodes, which were then fed into a density-based clustering algorithm that allowed us to identify individual clusters. We then expanded each cluster to a more statistically valid sample set of 5,000 episodes through a Monte Carlo simulation and analyzed those claims of those simulated episodes to produce the OPC cost curves. For this demonstration, we selected 3 breast cancer clusters for further analysis. These 3 clusters, we chose grouped episodes that were prevalent with ductal T1, ductal T2, and lobular T1 tumors. You can see some of the analysis on these OPCs in slides 8 through 13. The analysis revealed some unexpected results, such as a lobular histology of the tumor having a greater impact on cost of care than the size of the tumor itself, demonstrating why the Mason model is a more accurate way to set targets for cost of care. We also use this proof of concept to demonstrate the computational feasibility of quickly creating and updating these OPCs. We were able to cluster these episodes and produce cost curves in under an hour, and have determined methods to scale this performance to millions of episodes. First, indexing the data fed into the clustering algorithm reduces the computational complexity of the clustering process, meaning that instead of adding 25 additional computations for each additional 5 episodes, we are only creating an additional 11 computations. The more computationally complex process is actually the creation of the cost curves from episode claims. Frankly, though, this is a common problem in the field of big data analysis with numerous well-supported solutions such as Hadoop, Spark, and BigQuery that create parallel processes which divide up the work. RS-21 has experience using these kinds of technologies to process many terabytes of data in hundredths of a second. Finally, we have implemented several techniques to determine what are cancer-related costs and what are non-cancer-related costs. The way in which the Monte Carlo episode simulation selects claims ensures that non-cancer-related costs will not be common in the simulated data sets. Furthermore, setting baselines of costs with HCC data and other statistical models such as isolation forests can further filter out costs that practices have no control over. We appreciate PTAC's time and attention and look forward to answering questions.
Thank you. So we're now going to open it up to the committee to ask specific questions of the submitters. Bruce?
So let me get this straight. You have developed the oncology payment categories. Have you developed them for all of the cancers that you propose to include in the model? And if so, or even if not, is the methodology and/or the categories themselves proprietary, or are they available for use by others outside your organization?
So the first answer is no, we haven't gone through the process of doing it for all of the several hundred tumor types that are out there. But I think what our goal was for today was to demonstrate that this is indeed possible. We used the claims data from the come-home practices that we had, plus their clinical data to generate this, and just selected this one as a demonstration so to show that we could do it. Equivalently, we could take the claims data for colon cancer patients or for prostate cancer patients and create the same process. And as for the proprietary nature, I'll refer that to Cameron.
The analytical methodologies themselves are not proprietary. They're open source and freely available. They're very well documented. The expertise that we've provided is in combining those with big data applications and processing services to make the generation of these in a timely manner feasible.
Len.
So thank you for that. You mentioned that you had 2,500, I think, patients from the Come Home, and you had the clinical data to go with the claims for them. How many patients would it take to do, not all the cancers, but some 25% of all cancers or something, to create a critical mass of OPCs for a larger range of cancers? How many? Because my concern would be Medicaid, and Medicare has lots of claims. They don't have EHR data. Where can we get enough EHR data to replicate what you've done for Come Home?
So I have Terrell Jordan here to represent the National Cancer Care Alliance. This is an organization of 16 practices, independent practices, coast to coast, who are all on the same EMR, essentially. I think there's one or two who are not, who have all agreed that they're willing to participate. So we see about 75,000 new patients per year, have about 500,000 patients on treatment for various tumor types. So with access to claims data, which would have to be supplied by CMS, that we think that that would be sufficient numbers to generate, especially for the more common cancers. And do you want to comment on that?
Given RCCA's involvement in value-based arrangements, we wrestle daily with the avalanche of data necessary to manage cancer care patients, and we are intimately acquainted with the need for robust analytics. A deeper integration of analytics into clinical practice is a primary goal of modern healthcare. Data-driven decisions are fundamental to practicing medicine in an increasingly complex environment, and data analytics are essential to modern physicians' delivery of high-value, patient-centered care. Physicians face the challenge of a landscape exploding with clinical therapies and diagnostic tests. Physicians are finding it challenging to make the appropriate diagnosis and decide the most favorable treatment plans. In fact, the pace of growth in medical information makes it difficult for physicians to keep up with the latest clinical research. Evidence-based medicine driven by data analytics is the key to physicians making sense of all this medical information. Additionally, physicians and their clinical staff must receive relevant information at the point of care to impact clinical decision-making most directly. The right information received at the right time is critical to patient-centered care. Physicians desire intelligent decision support with detail that is tailored to address specific patient needs. As such, private practices must integrate clinical data into the entire workflow to reduce the added burden of value-based arrangements on their physicians. Physicians able to execute evidence-based guidelines using algorithms driven by data analytics will deliver meaningful quality improvements. In addition, the larger pool of patients analyzed, the more stable the conclusions regarding the guidelines. This will enable physicians to provide more efficient and effective medical decisions. Yet private practices are facing extraordinary administrative burdens as both governmental and commercial payers begin shifting financial risk to physicians. To reduce unnecessary tests and procedures while ensuring the quality of overall patient care, practices will require technology to meet minimum quality metrics for value-based care. Hence, to adequately participate in risk-based arrangements, private practices require a full suite of data aggregation, analytic capabilities, and actionable reporting on behalf of physicians. Participation in a project like Mason will allow physicians to work toward a centralized analytic database and will enhance performance reporting of all the participating practices. This will significantly further the evidence-based decision support necessary for physicians to successfully navigate Mason or similar value-based programs.
So clearly they anticipated the question, but what I really want to get at here, and that was great, you figured this out. But what I want to know is, if I heard the PRT correctly, they're worried about a time frame of updating the OPCs, of reclassifying a patient because of a particular pathway of their own disease, and you get the point. And you just told me you got to keep sending the equations out to the hinterland so the doctors can use the right one. So what's your idea of time frame of adjustments?
Thank you for the clarification. So we developed the proof of concept explicitly to kind of address some of these initial questions about the feasibility of quickly updating this data given the changing in cost structures and adding new patients into the clusters. Our initial results, as I mentioned, were able to be produced and computed in under an hour. We believe that that's feasible to scale up to larger numbers of claims.
This is Dr. Snow.
That was on a patient base of 5,000. So in a patient base of 500,000, it can't be that quick.
So this is, there are a few emerging technologies in the big data analysis space. That parallelization process that I mentioned allows us to have hundreds of computers working on this at the same time in parallel, rather than having one big machine deal with it. That's the optimization process that we have suggested based on our initial discovery, and we believe that we can hold that performance level up to hundreds of thousands or millions of episodes.
And to add in.
Angelo, we hear you trying to break in. We're going to let Dr. McEnany finish, and then we'll, okay?
One of the other concerns from the PRT report was the concern about switching an OPC. So if the patient were to select, for example, a high-cost provider, which is generally in oncology a academic surgeon with specific expertise in doing something, or proton therapy, or something that is not provided within a practice, then that patient would be referred, and that would be the endpoint of that OPC, because that patient would then not be being managed by that physician. Similarly, if a patient completes their block of adjuvant therapy, they would end that OPC at the end of that time and go on to like a maintenance OPC, which it would be much lower cost because they're basically getting a few office visits and maybe a few basic tests. If that patient were to relapse at the time of relapse, the restaging process would then assign them to a different OPC that would be there for metastatic cancer. To create these various OPCs needs to be an iterative process, because anytime you fix something in time and space and then medical science continues to advance, pretty soon you have a set of targets that don't reflect the reality of cancer care. And so by working with this group of practices who have agreed to open their EMRs to submit accurate data to us, so that when we discover things like lobular breast cancer is different from ductal breast cancer, which was a surprise to me as an oncologist of 30 years. I didn't think the cost would be different. That means that we can then retool and have that data submitted and then send it to the data feeds in the computer to be able to update that on a continuous basis. So part of the time frame of creating the OPCs for the really common cancers, the ones where it's really important to have an exact target, lung, colon, breast, prostate, for example, there are sufficient numbers of those in the database of the group of practices that those could be generated as the initial part out of the chute and then modified as science changes. If you're looking at something that's very rare, a Merkel cell tumor, for example, that I've seen 3 in my career, we may never need an OPC for that. They may not be something that it's worth the time and effort to compute an average price for something that is exceedingly rare. Does that help?
Yeah.
So Dr. Sinopoli is on the phone and he can't see the queue. So we're going to go ahead and turn to him, and then I've got Paul, Jen, and then I've got a question as well. So go ahead, Dr. Sinopoli.
So thank you. And so first of all, let me say I'm impressed with the comprehensiveness of your thought process around this. But one question. So are you suggesting that this be a single national database that's driven by a machine learning at that level, or are you envisioning this to be multiple databases that pop up across the country driven by multiple cognitive computer partners across the country? How are you seeing this scale out to more and more oncology practices?
So I'll start with, this is Barbara, I'll start with the answer to your question and turn it to Cameron. So we would start with this with the idea of a model that before oncologists across the country will be trusting enough of this that they're willing to accept the two-sided risk that is built into this process, we would need to be able to demonstrate its accuracy. And therefore, we would start as a pilot project using the NCCA practices and demonstrate that. So in that sense, it's the one data set that we would have in one common database that would get used. The concerns that the PRT suggested about are we using this one group and therefore the treatments are somehow idiosyncratic to that one group, I think is allayed by the question of using the NCCN guidelines, because that is a national standard of care. Then to scale this, it could be scaled with, I'll let Cameron talk to how the multiple computers and databases work with that. But to scale this, then once we've identified the processes that are there and identified the OPCs that are there, it'll be a little bit like telling all the hospitals in the country that they have to use DRGs. They figure it out pretty quickly. And so we can help then as well with, here's what the come-home processes are, this is how you use triage. We've seen that happen through the oncology care model. Multiple oncology practices have really switched over to embracing all of these processes that have shown to improve care. So I think once we prove it, then we will be able to encourage oncologists around the country and possibly other entities, other specialties that are managing chronic disease with acute exacerbations into using this kind of a process. So for the computing question, I'll give that to Kim.
Yeah. So we would need to evaluate the population as an entire set. The important thing to note there, though, is that geospatial location is taken in as an aspect when we're talking about what are the variables that we're looking at when we're determining similarity between clusters. As far as the computational feasibility of storing data that large, as I mentioned, we are experienced in the use of these decentralized storage and computing solutions that prevent us from having a single source of failure, either geospatially or technologically.
Thank you.
Paul?
Thank you, and thanks for bringing this forward. So the first question, I apologize, I might be a little slow, but when Bruce asked about is any of this proprietary, I wasn't sure I heard a yes or a no. So could you just clear, I mean, I heard follows some of NCCN, but so is it yes or no? Is some of this proprietary or not, if someone were to participate?
I can't speak to the data, but the analytical models are not proprietary.
Okay, so no is the answer.
No.
Is that right? Okay. Great. And then some of the discussion makes me think back to Hackensack, which came forward with CODA. And so, I don't know who would like to answer this, but I'm just curious how you comport their model or what they brought forward with yours, just if you had any sort of reactions to that.
Well, our Regional Cancer Care Associates is a separate organization, so we're not actually part of Hackensack and weren't part of that presentation. So
you're not familiar with the CODA?
I am familiar with it, but I'm not.
So I'm not asking you to represent CODA necessarily, but just your thinking. Again, they were sort of using algorithms to sort of be more specific around the therapy.
Yeah, I wouldn't want to comment on someone else's model because I might say something out of turn.
One of the things that I can say with this one, I've read the CODA, but I don't really know that model, so we did not incorporate that into this. One of the things we tried really hard to do with this model was to build on constructs that are already in place and familiar to CMS. CMS would have to continue to pay claims in the usual fashion. They're very good at doing that. They can pay facility fees. The OPC, we figured, would look akin to a DRG or an APC. So we're trying to use constructs that would be more within the computing normal business work of CMS. And so the CODA project seemed a little different to me from that.
Jennifer?
Thank you very much for your presentation, and specifically thank you for creating a model based on digital health innovation that can improve care delivery systems. I have two questions germane to Criterion 2 around quality and cost. The first question is around who will be paying for access to these pathways, and then also who will be paying for the cost associated with the OPC algorithm updates. And then I'll ask my second question.
Thank you. So for the access to the pathways, one of the concerns that I had at the beginning is that most of the pathway vendors are proprietary, and they do charge significant amounts more than I can afford in my practice to have those. So I reached out to NCCN, who is the source of all of these guidelines and who are here today to comment during the public process. NCCN is open source. I think that having the medical literature become proprietary is unfortunate, and I think that having an open source process for the best care is the best way to spread that care across the country. So we're very much looking forward to having NCCN work with us on this. You know, for the costs of developing it, all the costs of developing any sort of a payment system have to be filed into the process of the payment system. If we look at, for example, the quality withhold here, or we're looking at the cost now that an ACO uses to create its models, the savings from the models have mostly gone back into creating the IT infrastructure for those particular models. And frankly, some of the payments that we would be getting would be able to be funneled into doing this. There would, you know, we have to pay all these data geniuses to do their work and to be able to come up with this. So there is some infrastructure cost to any payment model. However, having it be electronic and having it be visible through the CMS processes is very appealing, because that's significantly less than the amount that we pay to submit a claim to any of the commercial payers, et cetera. So I think that it's one of the costs of doing business.
Thank you. And my second question is a piggyback onto a question that Bruce had asked before, and that's when describing this episode of active cancer treatment and then remission, when does that episode end? And a corollary to that is why were outcomes not described in the model? And then thirdly, this OPC algorithm readjustment, obviously it sounds like in your previous description there would have to be an adjustment based on active treatment versus remission. So if you could address that, all obviously related to this quality and cost question. Thank you.
So one of the frustrations that we had with the, as we participate, and we still are in the oncology payment, the oncology care model, is that not all patients get chemo. We have patients, prostate cancer patients, who are most appropriately watchfully waited on and observed to make sure that they don't progress, but they require a fair amount of effort, but they're not in the model. If a patient only requires radiation therapy, an early Hodgkin's patient, for example, the radiation oncologist is not in the model. And in this model, any oncologist could be the initiating consultation that would start that. As you go through the NCCN guidelines, they're very specific in terms of the options of therapy and the optimal therapy, and we would put into the models, and we have embedded into our electronic medical record, the pathway, the process of you need to have an echo at every 3 months for if you're giving someone Herceptin. You have to have all of these various testing at various opportunities. But we know, for example, in the adjuvant setting, that it starts with the first payment, or the first visit to the oncologist, and there is a point where adjuvant therapy is completed. And so at that point, that person would be switched to the different oncology payment category. So these episodes, in these episodes that we create, time is just one of the variables and not the defining variable, which I think strengthens it. For outcomes, I think producing real outcomes data for the first time will be an interesting byproduct of this, in that if we have the ability to take a patient who starts out with a given chemotherapy regimen or a given radiation regimen or any initiating event, we will then be able to look over time and see whether or not they activate the triage pathways more frequently than a different regimen would have them activated. So we'll be able to have the initial event, measure the toxicity in a very objective manner, and at the end of that episode, then we would be able to say what the outcome was. Outcomes in oncology can take years. So we would have the short-term outcomes of have you successfully completed all of the adjuvant therapy and how toxic was it, and therefore what do we have for the total cost of care, and then be able to do outcomes of regimen A versus regimen B, which I think will be incredibly valuable in helping oncologists understand when we're selecting regimens, when we're sitting down with a patient to say, if you pick this one, you can expect these toxicities. If you pick this one, you can expect these other toxicities. I think that will be incredibly useful to oncologists moving forward to be able to better help patients select what they wish to have. And your third question was so we will eventually get to outcomes, but outcomes on oncology can take years to really demonstrate. But as we develop these episodes, they can turn into bundles. And the eventual long-term goal would be to say, I have a breast cancer patient who fits in this OPC, let me have the bundle and go at risk for that. That's past where we are here, that would be the next phase, but I think that would be a valuable way to look at that. As for the OPC algorithms changing, were you talking about the updates or switching from one to the other? Both. Well, the switching from one to the other is a clinical decision. So that when a patient, say, elects, I'm going to leave your practice and go somewhere else, that episode would end. If the patient relapses, if the patient completes the planned course of therapy, then they would switch to a maintenance observation type of an OPC. So there are real clinical endpoints that we see in oncology all the time of where we could demarcate that. As for the constant updating of things, oncology is very fluid, and any payment scheme that does not reflect the ongoing changes that are occurring would give us targets we can't hit, or would give the adverse incentives of better avoid that patient with psoriasis who has this expensive drug, or this patient who has other comorbidities that are going to make them more expensive because I won't hit my target. We need to be able to have this process to say, okay, now we have the OPC, and we've learned that diabetics who have this particular problem, or people with food insecurity who have this particular problem, are going to cost at a different level. And we'd be able to get increasingly granular using the data science processes. Do you want to comment on that?
Yeah, on the frequency of the updating specifically, that process would need to be triggered anytime there's a significant change in the data that's being introduced. So any shifts in payment structure or costs. It would also need to change when we get a statistically significant number of additional cases, right? And that number will change as our population size gets larger. So adding 10 episodes into our set that we are evaluating is less impactful at 500,000 cases than it is at 500, right? We would be able to evaluate that and trigger it dynamically based on the size of the sets and the data that we're seeing.
Thank you. Thank you for your proposal and all of the work that you've done with the committee to answer all of our questions. I have one question that could be clarified. In the proposal, you call out under the quality section that the evaluation process will be done by the Innovative Oncology Business Solutions and select contractors. And so my question is the model reliant on the Innovation Oncology Business Solutions, or could there be another entity that provides that backstop? I'm just curious, and I don't want to say proprietary, but what's the reliance on that intellect in this model itself?
Actually, I would prefer to have that be evaluated by others. We worked, when we had the Come Home grant, we worked very hard to make sure that we supplied all of the data to that. So I look at the role of IOBS, which would have to be reconfigured because it does not currently, have all of the people necessary to help manage all these 16 practices produce the data. So what I would prefer would be to have an external process that evaluates much as happened with Come Home. And we would be the data suppliers to the external process.
Okay. So what you're suggesting is ideally you'd prefer that there be a different infrastructure set up to provide that input and takes IOBS out of it to a large degree. Is that?
Yes, I would think so. It's not ideal, I think, to have the person who's managing the model also evaluated. I think it's better to have an external evaluation.
That was my question. Thank you. Bruce.
Yeah, thank you for all this hard work. I've been sitting here looking at these very satisfying, slightly skewed to the right normal curves. If, and it's still an if we accepted that you have indeed demonstrated proof of concept, and I think that's something that is for discussion among the committee members, but if we accept it for the sake of argument, what next steps would need to be accomplished in order to actually have what's necessary to implement the model?
So in order to implement the model, one of the things that would be incredibly useful would be to have access to more claims data from CMS, because the more data we have to start, the faster we can generate these. And some time to, not excessive amount of time as Cameron has said, but to be able to pull the data sets, to look at the various tumor types and generate this immediate process. Then we have these practices that are willing to work with that so that we will have an internal validation kind of process.
That doesn't sound like a whole lot, and it doesn't sound like, well, how much time do you think is involved in that?
From an analytical perspective, as I mentioned, we can do this very, very quickly on orders of magnitude that probably aren't relevant for this discussion. The procedural part of that, of integrating that into the practices and into the model is, I think, where we would need to spend the time.
All right. So we're going to open it up. First of all, again, thank you. And you guys are not going away. You're just moving away from the table. You'll be here for the full deliberation and discussion.
Produced by the U.S. Department of Health and Human Services at taxpayer expense.